This presentation is designed to give you some insight into my approach in managing chronic ulcers, usually of the lower limb. As you'll see from this picture, the patient has an ulcer in the middle of the calf. The two lower pictures demonstrate histopathological slides demonstrating the presence of a skin malignancy called BCC. If you have a chronic ulcer that does not heal fairly rapidly, then occasionally this may be due to some underlying pathological process. It is important to have a biopsy of your ulcer before undertaking any treatment to outline the nature of the ulcer. Many ulcers that do not heal are due to skin cancer, autoimmune diseases, some chronic infections such as tuberculosis, and there are other exotic infections which can cause chronic long-term ulceration, which biopsy of the ulcer can help demonstrate and an appropriate management process put in place. Occasionally, non-healing ulcers may be due to a process involving underlying structures. In this picture, we can see 3 patients with ulcers of the first toe due to infection in underlying bone. We call this osteomyelitis, and occasionally the underlying infection can be due to the presence of a foreign body. When an underlying structure may possibly be involved, it's very important to do some extra tests, such as an X-ray of the foot, which will demonstrate both osteomyelitis in its advanced stage and the presence of a foreign body. When X-ray changes are subtle and the underlying pathological process is not evident, it may be important to perform a bone scan, as seen in this diagram at the bottom right-hand side. It is evident here that there is an active inflammatory process in the first toe, which demonstrates osteomyelitis in the bone. If these tests demonstrate a foreign body or osteomyelitis, it is important that the underlying process is addressed in getting the ulcer healed up. Osteomyelitis will require the administration of antibiotics and may require the removal of some of the infected bone. If a foreign body is present, clearly this needs to be removed to get the ulcer to heal. Most commonly, osteomyelitis is present in patients who have neuropathic processes, and the most common form of this neuropathic process we see is diabetes mellitus with peripheral neuropathy. Arterial ulceration is most commonly due to poor or reduced blood supply to a limb. As we can see in this picture, the ulcer on the left-hand side looks pale, lacking blood supply, and indolent. The edges are punched out, and this is a characteristic picture of an ulcer due to lack of blood supply. The patient underwent a femoropopliteal bypass graft to revascularize their leg and improve the blood supply to the ulcer site. Healing progressed rapidly, and as we can see from the post-femoropopliteal bypass graft picture, there is red granulation tissue and white healing skin on the edge of the ulcer. The ulcer will rapidly contract down, and healing can be quite rapid once the arterial supply has been improved. In determining whether an ulcer has an ischemic component, that is, whether the ulcer is arterial, it is important to do non-invasive vascular studies. Most commonly, these are Doppler studies which measure the ratio of blood pressure in the arm to the blood pressure in the ankle and the first toe. An ultrasound can also be used to demonstrate a narrowing in the arteries or a blockage of the arteries, as demonstrated on this arterial report. These tests are non-invasive and do not involve any risk. However, once they've been performed and it's been demonstrated that either arterial disease is present or is not present, this underlying problem can be addressed in an attempt to get the ulcer healed appropriately. As we can see in these diagrams, ulcers will heal relatively rapidly once the leg has been revascularized. This is a vascular ulcer that is occurring in an angiosome of the lower limb. Angiosomes are the areas of skin that are supplied by the 3 separate blood vessels in the calf. Once revascularisation has been achieved, rapid healing begins, granulation appears, and the ulcer will contract in quite rapidly. Not all ulcers will heal rapidly, and the healing process can be significantly delayed both by nutritional factors, age of the patient, and the processes that are used to treat the ulcer. However, given that all these conditions have been addressed, most ulcers can be healed by secondary intention within a couple of months at the most. A simple method that I use in my practice to manage many ulcers is viscopaste bandaging. Viscopaste bandages are a non-elastic bandage that is applied to the lower limb from the toes to the knee. The bandage is impregnated with zinc oxide, which is a cofactor for healing, and the bandage is left on for up to 2 weeks so that the healing process can proceed in an undisturbed nature without regular, frequent removal of dressings and interference with the healing process. Traumatic ulcers are well managed with the viscopaste bandaging technique. However, some time may be necessary to achieve this. In the event of a traumatic ulcer, it is possible to perform a skin graft which will achieve ulcer healing within 2 weeks, whereas use of the viscopaste bandage may require up to 3 months to achieve healing. The most important thing in managing many ulcers is to allow the healing process to proceed in an unimpeded manner. If constant dressings and irritating dressings are applied to ulcers, this process can seriously delay healing. Additionally, if the patient is nutritionally depleted, the healing process itself will be delayed. There are also drugs such as methotrexate and prednisone which can impede the healing process, and management of ulcers in the presence of these conditions can be quite complex and the healing process prolonged. Venous ulcers are an important group of ulcers. Most frequently, the patient has a history of DVT or the presence of varicose veins. These ulcers most frequently occur in the gaiter area, around the inner side and lower third of the calf just above the ankle. This is called the gaiter area. There is usually chronic pigmentation and scarring from high venous pressure. These ulcers can be healed by treating the varicose veins appropriately, by elastic or non-elastic compression bandaging and skin grafting, or a combination of all of these, depending on the patient's particular circumstances. In summary, every patient has individual characteristics and every ulcer has a group of individual causes. In managing your ulcer, it's important for us to work out the underlying processes that are preventing it from healing up. You need investigations to exclude arterial, venous and venous disease, and a biopsy will help exclude conditions such as exotic infections and skin cancers. Most ulcers can be healed, although the presence of impeding factors such as nutritional depletion and drugs such as prednisolone or prednisone and methotrexate can slow the healing process considerably.